Good afternoon, everyone. Welcome to our new webinar series, Let's Talk. Today, I'm joined by my colleague, Diane, and my name is Sandra. We are both occupational therapists. Chances are when you call the Practice Resource Service, you will speak with one of us. We're so glad you could join us this afternoon, and we welcome new and returning occupational therapists. Before we get started, today's session is all about helping you start on the right foot. And our goal is to share some insights, answer your questions, and also make sure that you feel supported as you continue on in your professional journey. To get to know each of you a little bit better, we're going to start a quick poll. There are 3 questions, so if you can just take a moment when they pop up on your screen to answer all 3 in the next couple minutes. These questions will help us just understand who's joining us today and may help tailor some of our discussion. We'll give everyone a few more seconds to complete the poll. All right, it seems like we've got a number of responses. So thank you so much for sharing. Now that we're all warmed up, I will turn it over to Diane.
Thank you, Sandra, and good afternoon, everyone. Before getting into the practice questions, we want to take this opportunity to let you know about upcoming elections at the college. Elections are coming for districts 2 and 3, and it's never too early to get involved. It's important for the college to have representation from a diverse group of OTs, including those who are newer to the profession or returning to practice. So this is your opportunity to make an impact and contribute to the profession. You can get more information about the districts and other election details by scanning the QR code on your screen. We'll give you just a second to do that. And now, without further ado, here's how today's webinar is going to work. First, this session is being recorded. For everyone's privacy, all attendees are set as muted with cameras off. We ask that you use the Q&A function to send us your questions. The Q&A button is located on the lower bar of the Zoom. This helps us to track the questions and to get to them in order. Please don't use the chat function. I know it's tempting to use the chat, but we may not see the question in there and we can't track it. So please use the Q&A. We will start by answering the questions that were submitted to us in advance. So thank you to those who emailed them in to us. Then we will go to your questions in the Q&A. After that, we will open it up for anyone who wants to ask their question live. To do so, just raise your Zoom hand and we will unmute you so that you can speak live. The camera will not activate, so it will be only audio. A reminder to please be mindful of privacy and don't use any client names or client identifying information when asking your questions. Lastly, we know we only have 1 hour, so if your question didn't get answered or you want to discuss any practice issues in more depth, Sandra and I are available for individual consultations, so please just give us a call or an email. Now, let's talk practice.
Thanks, Diane. So the first question that was submitted was how to assess if someone is capable of consenting and what to do if they are not capable, but there is no one to provide that consent for them. That's a question we get quite often. And really, to determine if someone is capable, it really is a clinical judgment decision. And so the question is, do I need to go in a room and say, I need your consent to speak with someone? And the answer is no. You're trying to get to understand this individual. So what you're trying to obtain is, can this individual understand the nature of your service that you are proposing. Are they able to retain that information? Are they able to appreciate the risk? And that may be understand the reasons behind the options that they have to be able to consent to, or can they express their decision or gesture their decision? And if not, then you need to let the client know that you are feeling that at this moment in time, they are not capable of understanding the occupational therapy services that you are proposing. And if you refer to our standard for consent, there is a substitute decision maker hierarchy, which is a legal outline of all the individuals that potentially, in the order of priority, that can provide consent on behalf of the client. Now, we encourage that if you deem someone not capable of providing that informed consent, that if you are including a substitute decision maker, that the client also is included. And if the substitute decision maker is providing that consent, that you do that transparently in front of the client. And if not, if there is not someone that can consent, and you've already gone down the substitute decision maker hierarchy, you know that at the end there's a public trustee and guardian that can be contacted to initiate that they will make the decision on behalf of the client. We encourage that you discuss this with your team, because chances are, if you're having difficulty obtaining informed consent from a not capable client, that your team also will have those same concerns. And a follow-up question to consent is, what does documenting consent look like? And of course, we encourage that you avoid those vague statements like consent received or consent obtained. And the reason why we say that is, in 2 years, if there is a concern, it's really challenging to recall what that consent process is. You can refer to the standards of consent as per your organizational requirements for consent, but we would hope that a documentation for consent includes what you explain to the client, what was their understanding, indicate the type of consent. Was it verbal? Was it verbal and with an accompanying consent form? Was the substitute decision maker involved? Was a translator involved? And what was agreed to? Was it all of the proposed service, or were there some limits to that service? And I'll turn it over to you, Diane, for the next question.
Thank you. So the next question we received was how to negotiate salary as a new OT. So great question, but this is not something we address at the college. The college's mandate is to protect the public, so we defer advocacy issues to our professional associations, like CAOT, the Canadian Association, or OSOT, the Ontario Society of Occupational Therapists. So reach out to them, because they will have resources on things like how to negotiate salaries or pay rates for OTs. The next set of questions that we received pertain to providing virtual services. We actually received quite a few of them, so I'll try to address all of them here together. The questions were about whether you can take a job that requires virtual services outside of Ontario. Can you do virtual while living internationally? And can you only work in Ontario if you do psychotherapy virtually? So when it comes to virtual services, you need to still uphold the standards of practice as you would for in-person services. But there are additional considerations around consent, privacy, boundaries, safety risks, and of course, jurisdiction. So before providing any virtual services, please review our virtual guidance document that goes through all of these considerations. You can find all of our guidance documents on the COTO website. If you are thinking about taking a job that provides virtual services to clients outside of Ontario, you should check with the OT regulator of the other province or the other country to ensure that you're allowed to provide services under your Ontario license in that location where the client is physically situated. And the same goes for if you are living in another region and wanting to do virtual services under your Ontario license. This is important because other regions may have local rules that we have no jurisdiction and no control over. They may have different privacy rules, or they may have different rules for OT scope of practice. So it's important to check with the other OT regulator, and in doing so, confirming with them the type of OT service that you're planning to do as well. Because with psychotherapy, as an example, it is legislated differently in other provinces. So you may need special authorization to do certain activities such as psychotherapy. They may have restricted acts or controlled acts that they won't permit you to do, or they may possibly require registration in that province or in that region. So the general rule of thumb when it comes to virtual and it involves another jurisdiction, check with that other region's OT regulator and clarify the type of OT service that you want to provide under your Ontario OT license. And I'll pass it back to Sandra.
Next question is, if someone is considering to return to OT practice part-time, are COTO registration fees reduced or prorated? And the response to that is the same registration fee exists for all registrants. At this time, we don't have reduced fees for OTs who work part-time only. We do have fees that are prorated by quarters of the fiscal year. And on our website, we do have a fee table where there is a breakdown. So it's the link is for COTO fees and tax receipts. And also, if you want to know more about how the college fees are spent, we do have a page with the frequently asked questions on understanding the college fees. And if you have additional questions, feel free to contact us, and then we can address those questions geared towards your specific situation. And the follow-up question is around temporary registration for internationally educated occupational therapists. And so this is primarily a two-part question, because temporary registration, if someone is coming from outside of Ontario to work here in this province or outside from another country to work temporarily, or, for example, to give a workshop, to teach, then potentially a temporary registration can be accommodated. What that would include is that you reach out to the registration program and they will gather more information and the necessary documentation to determine if a temporary registration would be granted. If someone is internationally educated and wanting to permanently come and practice here in Ontario, they will be typically required to go through the CEAS program, which is the Substantial Equivalency Assessment Systems. And that is a different process. On our website, we do have information to help individuals understand what that process is and what that entails. And we encourage you to reach out. Again, there are many nuances to different OTs and that are internationally trained, and we want to be able to provide specifics geared towards that individual situation. So you can either contact practice@coto.org, and we can forward your email to registration@coto.org, and they'll walk you through that process. And turning it over to you, Diane.
All right. The next question on the list is how to document references to organizational policies for processes around consent and use of abbreviations, etc. So the standard for record keeping is not prescriptive. So the college doesn't prescribe how OTs should specifically document, as it could look different from one practice setting to another. So, for example, in some settings where there are electronic records, an OT may be able to check off a box that refers to a specific policy or it describes the policy. While in other settings, if that capability is not there, it may require the OT to specifically write out the policy that they're following or the process that they were following. Because it can vary from one setting to another, it's really best to discuss these at the organizational level to ensure that there is consistency in how all the OTs are documenting. What's important is that if you are referring to a policy and this policy is stored separately from the record, that the location of where the policy is stored should be noted, and so that it can be produced if the record is requested down the line. The next question we received is about the QA process and audits. So there actually was not a specific question sent to us, just questions just about the general topic. People are interested about the topic in general. So what we recommend is first go to our website because you can get quite a bit of information about the annual QA requirements for OTs from the website. There is a requirement to complete the annual learning plan and the annual e-learning module, but you could also get information that's posted about the competency assessment. So we recommend you reach out to the QA team. They are really the best suited to clarify any questions you may have. They are occupational therapists themselves, so please reach out to them by phone or email, and they will be more than happy to connect with you. Over to you, Sandra.
We have another question. What happens when a family member gives you information and tells you not to tell the client? And that's a great question. And in a perfect world, we'd be able to have a response that, you would want the family member to know that once you collect that information, you can't uncollect it. And if there is any risk of harm, that you will have to address it. And so sometimes if you know that someone wants to let you know something, it could be also helpful. It could be collaborative. But I think being transparent to the family member that the client, you are treating this client and you have an obligation to be transparent with the client and to try and encourage that the information that they want to relay is important for the client to hear so that it can be addressed. And we know sometimes that it may be due to fear. And I think it's fair to ask the question around, is there imminent risk of harm to the individual or to others? Because then the consents, then you have the Personal Health Information Protection Act, which says that you do not need consent if there's that threshold of imminent risk to hear that information and act on it. And so I would just suggest my point is to try and manage before that information comes out, the expectations with the family member. And one of the final questions that I will be responding to, and then I'll turn it back over to you, Diane, is someone would like to know more about the requirements when returning to clinical practice after several years of non-clinical practice. And really, that is a question that is very specific to the individual. It depends on what area of clinical practice you're returning to, what are the level of risk are controlled acts involved, and there isn't a formal process that the college has undertaken, but as OTs, we expect OTs to be providing competent so that they have the knowledge, skills, and understanding to carry out any activity that they will be performing with a client safely. And so what does that look like? Does it mean professional development? Does it mean having mentorship? Does it mean that you have to review all the standards of practice? Does it mean that your employer will be doing that training? And the example that we have to draw on is, do I dare say, the COVID era, where the skills are there, but the training to upgrade was necessitated. And so OTs need to do that reflective piece. And as we know in our quality assurance annual tools, that could be part of what you're working towards. And you will always have the college. You can also reach out to the associations that have tons of resources around best practice for specific practice areas. And that is where we would have someone start in terms of transitioning from non-clinical to clinical. Diane?
Okay, I've got just a few more questions that I need to get through here on my list. So the next one is how to use AI in virtual sessions. So if you're thinking about using AI in your practice, whether it's virtual or in person, you need to consider things such as consent. So you want to make sure that you're obtaining clear consent from your client to incorporate AI into your practice. You'll also need to consider privacy. Is there personal health information being entered or captured by the AI? How and where is the AI information being stored? You'll also have to ask yourself if the AI is giving you information that is accurate and reliable. We all know that AI can generate false or biased information. So at this time, AI still needs human oversight, and you are still accountable for the work and service you provide. So the college does not have a specific rule that prohibits the use of AI, but we do advise OTs to consider all the pros and cons, obtain client consent, research the AI platform or technology that you want to use. And if you work for an organization, look into what their policies are for using AI. We do have a Q&A resource on our website on what OTs should consider if using AI, so have a look at that as well. The next question is around transfer of accountability and how to manage that when in a hospital when there's no OT coverage due to staffing issues or budget cuts. So we recognize this is a tough situation as resource limitations are beyond your control. So your focus really just has to be on how to proactively manage risks to the client. So knowing there will be no OT coverage, what is the communication to the client and to the team so that everyone knows what to expect? Will there be OT, if there's no OT coverage, will OT treatment be put on hold? Are there alternative models of care while the OT is away, such as other group therapy options? Is there a need to identify the clients who are at high risk of an adverse event? And if so, can they be monitored or referred to other health professionals? So it's really about working with your teams and leadership within the organizational limits and putting a plan in place to manage client risks and documenting this process. OTs are expected to provide a rationale if they need to deviate from the standards of practice. So this documentation will be an important part of your process. The next question is, what would someone need to do to be able to transition from mental health counseling and to eventually incorporate CBT? So psychotherapy techniques carry risks. So OTs need to ensure that they have the competencies to perform any psychotherapeutic technique safely. So to start incorporating a technique like CBT, OTs need to follow the standard for psychotherapy. And the standards requires that OTs first obtain the appropriate training through courses or workshops, which have instructional and theoretical components. And then two, to obtain psychotherapy supervision. And the requirement is to obtain at least 50 hours of supervision in their first 2 years of psychotherapy practice. So again, anyone that's thinking of moving into psychotherapy or incorporating psychotherapy into their practice, we recommend you start by first having a look at the standard for psychotherapy, and you can call us for more questions if you have those. And the very last question on our list is related to private practice and consultation services and how to document. So any OT that wants to start a private practice essentially has to manage the business side of things in addition to meeting the standards of practice for providing safe, competent, and ethical OT service. So we have a private practice guidance document that will help you to start thinking about all of these things. And this includes getting your own accounting and legal advice as you set up your business. As I said, the OT work still needs to meet the standards, and this includes the standard for record keeping. But as a private practice, you will likely have to consider, how will you document? Will you need to develop your own templates to ensure you're capturing all the relevant information? And how will you set up your records and management and storage system as a health information custodian? How are you ensuring you're following privacy laws? So there's a lot to think about when moving into private practice or thinking about doing consultative work in this way. The associations, such as OSOT and CAOT, they have private practice resources and sector groups where you can connect with other private OTs. So that's a really good resource as well to support your work. So I think this brings us to the end of the pre-submitted questions. I'll hand it over to Sandra.
And there's one more question that I missed. So there was one question around the circle of care. And when we talk about circle of care, it's a reference to a group of the healthcare providers who are involved in the client or patient's care that need to share personal health information amongst them. That can range from family physicians, specialists, nurses, allied health, community agencies. Now, circle of care is a term that's used to indicate that there's that implied consent, that you're sharing this information amongst those who have that direct care of this individual at that time. Doesn't mean that a healthcare provider that provided service 3 years ago will have that information. There needs to be that the client has given consent to the primary and those who are involved in the care. For example, if a physician is referring the client to an OT, that information will filter back to the physician because they are included in that circle of care. And so really it is for OTs to understand if there's expressed withdrawal of consent to share to a specific individual, then that means they have now gone outside of the consent and that the circle of care. And that means that that individual, the OT, can note or write back to the referring individual that the person has locked their information. And that would mean that the referral source would have to explore why the information needed for their healthcare purposes is now locked down by them. There may be many reasons. The examples of, for example, if you're in a hospital, that's the easiest because, the service that's being provided within the hospital environment, those in that practice setting are included in the circle of care, unless, again, there's express withdrawal of consent to share with someone. And in the community, it could be the pharmacist, it could be physio OT or other speech language. I think an example that would be clear who's not in the circle of care, it could be the police or insurance companies. They are not healthcare providers in the direct circle of care. And so we'll stop there. My apologies for missing that one. the IPC does have a great resource on Circle of Care. So the IPC is Information Privacy Commissioner of Ontario. They have great fact sheets, and I would encourage you to look at that document. They also have frequently asked questions about Personal Health Information Protection Act, and there is a section on Circle of Care. Okay. So as Diane had explained earlier, we will go to those questions that you want to put in the Q&A section of Zoom. So we have a couple questions. One is a question related to the question around what if a family member wanted to provide information and said not to let the client know. The follow-up question is, in a PED setting, if a parent asks you not to share something to our clients, what do we do? And I think as OTs, in our standards of practice, you'll notice that there is a section in the introductory of the standards, and it talks about using your clinical opinion and judgment. And it says when you're applying the standards or you're gathering information, you're going to determine what's in the best interest to meet the client's needs. And so it's you as the OT that will have to speak to it. As I mentioned earlier, you just want to have the parent or the family member understand that not all information that they may provide to you can be kept confidential, especially if it's something where the child is in need of protection, because you have those regulatory obligations that you must act. And so it's just managing those expectations. You may well receive the information and determine that, okay, they want to let you know that, this behavior is consistent, or I'm just using hypothesizing, but really at the end of the day, we rely on you as the OT to know that if you get this information, sometimes you may not know what you're going to do with it. You can always call us, and we do get those questions, something that someone has received that is atypical of information that an OT would have, and we'll try and direct you where to go, who you need to speak to, and how to document those conversations.
Great. I can take the next question in the Q&A. So there's a question about methods that can be used to maintain privacy standards when working from home and using dictation functions to write client letters, chart notes, or emails. So it's a good question. Similar to what's we've been talking about, there's a judgment that needs to happen on the part of the OT because everyone's situation is a little different. The standards and the privacy legislation requires OTs to put in as many reasonable safeguards as they can to maintain privacy. So what those safeguards are going to be individual, but generally speaking, if you have a home office, for example, we would expect you to consider environmental safeguards, for example, to start. Like, are you in a private space if you're dictating information that contains private information of clients? And then how do you store this information? Is it stored in a paper format, in a filing cabinet, where back in the day we would expect the filing cabinet to be locked? Nowadays, is it stored on a desktop? Is it stored on a USB? Is it stored on a cloud system? And what are the privacy settings for those? Is it encrypted? Is it password protected? And then there's the privacy considerations of then how you share that information, and getting and ensuring if you are disseminating or emailing information, how you're doing that to ensure it's secure. So a lot of it might come down to looking into the technology that you're using, getting the help from technology experts to ensure the systems you're using are secure, and just looking at your own practice and ensuring you're not disclosing any information or inadvertently um, emailing or sending information or even speaking in a space where information gets disclosed, and you might breach privacy in that way. So,
We do have the guidance document, Privacy Legislation and Occupational Therapy Practice. That's a good foundational document. Also, the Information Privacy Commissioner has many fact sheets that you can access. They are the ones that um, oversee PHIPAA and privacy breaches, and even some of their cases that comes to their attention are helpful in terms of mitigating approaches or strategies to mitigate any privacy issues that you may have when working from home.
thank you. If anyone has any other questions, we welcome you to enter it into the Q&A. At the moment, we don't have any more in the Q&A, so we can open it up for a live questions. Oh, we do have one more in the Q&A. So the question is, reviewing the document on working in managed resources, can an OT work at one site with multiple models of care? Direct one-on-one with some clients while consult with others. So I can start by answering yes, an OT can work at one site and have different roles and therefore use different models of care in providing service. A lot of that will come down to the organization and what their policies are, how their roles are distinguished. You know, I would imagine that they are with different programs, perhaps, or different clientele. Um, but generally speaking, yes, an OT could wear different hats, so to speak, in one organization and perhaps provide care in one way to a group of clients and then perhaps provide service in a different way to another group of clients.
I think just to add on to that, an important aspect of that is ensuring that your team understands your service and what you can provide. And that also speaks to the clients, that they understand what your role is in a specific, whether it's a unit program, and that you can reference something, that it's written down. Because oftentimes when those discussions come around, um, people, nurses, other staff may see you in one environment and may expect that you do the same thing in another environment. And that's not the case, because this is what you've been asked to do in terms of just giving a consult, which means that you're not having that one-to-one. And also, we get questions around from clients, actually clients that are seeing that an OT may come to see another client in the same unit 4 times a day, or that's unrealistic 4 times a day, but frequently. And why isn't their loved one getting that same care? And it may be just that, in alternative level of care, many people from different programs may be housed in one location. And so that's why I think that transparency and clarity around your role for the client is communicated. Let us know if you have any follow-ups to the questions, if you're looking for more information.
So the next question in our Q&A is, what is the regulation for enforcing that client data is protected by the therapist?
So
Go ahead, Sandra.
what is the regulation? It's the Personal Health Information Protection Act. That is the act provincially that requires any health care provider regulated that they are keeping that information and data protected. Diane mentioned earlier around the use of AI and making sure that you have a good understanding of where that information is located or how that information may be used. I think we are still waiting for regulations around that, but the core is understanding what privacy legislation your practice setting falls under. Most in Ontario could be PIPEDA. It could be, if you work in the insurance, it could be PIPEDA. And so our expectation is that you understand, take a look at that guidance document to understand what privacy legislation you fall under.
Great. Thank you for your questions in the Q&A. We don't see any more at this time, so we can open it up if anyone wants to ask their question live or provide any follow-up questions to what we've already talked about. You can raise your Zoom hand and we'd be happy to unmute you so you can speak live.
There is one more question that just came in. Transfer of accountability is the question, and it's around to areas where, due to low staffing, unable to fill a leave or new job position or funding. Example, ICU, no funding for OT directly and no one assigned. There is no OT in that area, large organization. So the question is around transfer of accountability. I think you touched on it earlier, but this has a bit more specifics when there's low staffing.
Yeah, we did touch on it earlier in one of the pre-submitted questions. It might have been yours as well. So we recognize that these are tough situations to be in when there is no funding for OT service, and it's a situation beyond your control. So at the end of the day, you can only control what is within your sphere, and so really, if there's no OT coverage, it's about what can you do to proactively manage the client risks. And so it may be to ensure there's clear communication about what is available and what is not available. You know, if an OT goes off on a vacation or they're taking a leave and there is no OT coverage, being clear to the client what that means for their OT service. Does it mean their service is put on hold? Does it mean their service is discontinued? Does it mean because they have ongoing needs, perhaps there needs to be a referral to other healthcare services or other providers? Is there a need? What is the communication to the team then in terms of what happens to the OT service? Is there a need to identify those clients that are at risk or at high risk of an adverse event because there is no OT service now? And if so, how are those clients going to be monitored or perhaps serviced or perhaps, monitored so that the right service can be provided to them in a timely way? So it really is just about managing proactively as much as you can to communicate what's going to happen, what they can expect, what are the client risks, and do other professionals need to be aware or referrals need to happen so that the client is best served.
Mm-hmm. And oftentimes it may seem like it is an uncomfortable conversation, but I think organizations understand risk. And we've always said that OTs should take a risk-based approach. And even by highlighting some of the concerns, I think it's important. And sometimes even offering the solution because sometimes the right hand and the left hand don't know what's happening. And sometimes OTs have the best solution. And so not feeling fearful that you can't put that forward. We talk also about, it's hard not to get emotions, but to remain objective and to be solution focused, right? We recognize that you're working for an organization or an employer, and we don't want that relationship to be eroded. But what we always want to focus on is what's in the best interest of the client.
And we have a question in the Q&A now. So the question is, what is the pain points college has? What is the pain points college has to audit therapists? Do you have tools covering all you need to run the audit process from start to finish?
But the quality assurance program does the competency reviews. All of that information, if someone is selected, is available to those going through the competency review process. I'm not quite, do you, meaning the college, or will you be provided with all the tools? That is, yes, you will be communicating with the quality assurance team. If you have a question, they do webinars if someone has been selected for the competency review, and that's also an opportunity before you actually start the process to answer the questions. They have a team, as Diane mentioned, that are occupational therapists, so they are happy to take your questions and discuss your specific situation.
Great. Are there any other questions that anyone would like to pose to Sandra or myself? You can either type it in the Q&A or you can raise your hand if you are so brave to speak live.
If not, we understand the hesitancy. Um, this is our first of, we hope, many, where we can offer just any OT to ask their questions. Again, we try to maintain confidentiality. Diane mentioned earlier that we're available for one-to-ones. We can book a time to speak and talk through it. You do not have to provide your name. It's confidential. We want you to feel as comfortable as possible to answer your questions within the limitations of what we can offer. But we certainly will problem solve with you other resources that you may be able to access. So please feel free, and we will accommodate your time. We know that, the way the health system is working, you're very busy. So even if it's a little after work hours or before, we can make ourselves available.
So, in our Q&A, someone has to go off to a meeting. And thank you for the session. Thank you for joining us. We appreciate it, and we hope it was helpful. We do have one more in the Q&A. I'll read it out. If AI is used in a PIPEDA compliant, if AI is used and it's PIPEDA compliant and reviewed after generating information, why does this need to be consented by a client? Since if I did a search online, I would not be asking for consent for this, or should I? So I think there's slightly two different things. An AI device might be compliant with privacy laws, which essentially means the AI platform, they might consider themselves that they've put in things to make it private for healthcare provider use. But that's a little bit different than you working with your client and then using an AI platform or an AI program, because the client doesn't know about it. So even though it's private, a client may still not be happy or agreeable or know what this device is. So anything that you're introducing into the work that you do with a client, it's really about being transparent and so that the client has all the right information to be able to make an informed decision about their OT service. So they still have the right to say yes or no whether they want that OT service, knowing that the OT service you're intending to provide now includes an AI program.
Right. And, if we can give just a brief example, if you are using AI and you're looking for, let's just hypothetically say, resources, and you're going to present this to the client and, not understanding perhaps the client's, the social factors. Can the client access it? Can the client, is the client agreeable? Just having a transparent conversation of where this information or the recommendations came from can go a long way. There was a situation where a client was asking, like, I don't have access to this. I don't have the resources. I don't have the time to travel to this place. And so they were asking around, how did the occupational therapist come up with this information? And again, the use of AI is not prohibited, but it's just that the clients have a clear understanding that that's part of the service that they will be involved in. Oh, I have a few more questions.
Yeah, the second one is, can you please repeat what was said about a one-to-one session with you and how I can set up that meeting? So I assume you mean with us. So yes, you can email us at practice@coto.org, and we will be able to get back to you, set up a time. We can do it by phone. We can sometimes do it over email, depending on the question. We're also happy to do a virtual session. So whatever suits the need and the type of question that you ask, we can accommodate. And a follow-up, I guess, to the AI question. We have another one in the Q&A that says, following on the last question, do you need consent to use AI for dictation, note generation, if you are not using any personal health information? I assume the dictation and generating a note is for the client record. So I I I think that usually means there's some personal health information, but anything that involves the client. So if you are dictating a note about a client's session, OT session, and it goes into the clinical record, then you do need client's consent. Because at the end of the day, you don't want a client to say, I didn't know. I didn't know that my OT had a device that was generating a note. I guess I'm not entirely clear. Is this device listening to your session and generating this note, or is the OT just speaking into a dictation system? So I think some of it might depend on maybe the device you're using, but the rule of thumb is yes, anything that you are going to be using as part of your OT service, you should obtain client consent. So the follow-up comment that we got is no, just speaking into a dictation system that uses AI following an appointment, leaving out identifying information. So you're using an AI system just for scheduling, it sounds like appointment scheduling.
I I I just went through this for there is usually with the consent process, there's the understanding that you're using an app to schedule, and the most recent one just had a disclaimer so that you understand that and what you're agreeing to be notified, whether it's um, by text or email. So there are sometimes built-in disclaimers, but you need to let the client know, right? We use I don't know, Jane app to schedule appointments or to do our notation. And then, that opens up that conversation if they have a question or a concern about it. It's just really that they know.
Okay, just looking at the clock, it's now 12:57. So I think we are going to wrap up here. I don't see any outstanding questions. So we just want to thank everyone for joining us today. And I'll hand it over to Sandra for any last words.
Well, we thank you for joining us today, and um, we will have this available for review, as we had indicated when we pushed out the communication. If you have any questions, please do not hesitate. I know with an hour, we can't take a deep dive into all the questions, but we will be having a, a survey that will be sent to you. It's 2 questions. Just how can we improve? And hopefully you got something out of today's session, if not even to just call us and ask us further questions. So thank you very much for taking the time out of your busy day.